I'd like to introduce today's speaker, Samuel Rogers Melnick. Samuel Rogers Melnick currently serves as an integrative health research and data specialist with the University Hospitals Connor Whole Health in Cleveland, Ohio. Sam is also pursuing a PhD in clinical translational science from Case Western Reserve University. Sam served as a lead investigator for 2 consecutive research grants from the Kulis Foundation that funded music therapy research studies in sickle cell disease. Sam's current research focuses on the clinical effectiveness of integrative modalities throughout the university hospital's health system, with a particular focus on music therapy and massage therapy for individuals with sickle cell disease. So without further ado, I'll turn it over to you, Sam.
Thank you so much for that introduction. Even though we can't be with each other in person, I wanted to be able to give you an example of how music therapy works, and actually in this virtual world that we're in. And so one of the exercises that I often do with patients is to use music as a way to facilitate taking deeper breaths. And as you take deeper breaths, that's helpful for relaxation, stress reduction, dealing with pain, and things like that. And I know there's different ways that people teach breathing exercises. Some kind of get pretty complicated and intricate. The way I often tell participants is want you to put one hand over your chest, and you can put one hand over your belly button. And imagine that there's a balloon behind your belly button. And as you breathe in through your nose, you'll feel that balloon inflate behind your belly button, that lower handle rise. And as you breathe out through your mouth, you can feel that balloon deflate. And that helps to promote a way of breathing that gradually inflates the diaphragm, deeper breaths over time, that kind of thing. And so I'm going to walk you through an exercise where we're going to listen to some music, and that music is going to gradually facilitate some deeper breathing. So right now, wherever you are, whether if you're in a busy office or I hope you're not driving, but I'd like to invite you to find a comfortable position, get situated, feet flat on the floor, and find a position in which you can relax. And right now, I just want you to become aware of your breathing. Don't need to change it, but with that one hand on your chest and one above your belly button, simply just notice how you're breathing. And you can notice where you're breathing from, whether your shoulders are rising and falling, whether your chest is rising and falling, maybe your belly is rising and falling. And you can notice how your hands move as you breathe. And as the music begins, I want you to notice the rate of your breathing. Are you breathing rapid or slow? Are you breathing deep or more shallow? And as you slowly take that deep breath in, I want you to imagine the air is flowing deep into your belly. You can feel that belly fill with air as your lower hand rises. And then follow that breath out as you completely exhale. And slowly taking those deep breaths in, let it out. You can let any tension melt away as you relax more and more deeply with each breath. You can notice how that air feels. This cool, fresh air enters your nose, passes through those hairs in your nose, reaches the back of the throat, goes deep into your lungs. You can notice what happens is that breath of air enters your lungs. And what happens when you exhale? You can feel the temperature of each breath cool as you inhale and warm as you exhale. You might start to notice that your breath is becoming a little more smooth and slow as this beat becomes a little more smooth and slow. You can feel your belly and rib cage expand outward with each breath, and feel yourself become a little more and more relaxed with each exhale. You can allow your shoulders to become a little heavier with each exhale. And if your mind wanders, off to the to-do list or the grocery list, it's all good. Just bring your thoughts back to the breath and the music. Again, slowly taking that breath in and letting it out. You can feel yourself become a little more relaxed with each exhale. And as I count from 5 down to 1, just want you to become a little more alert as we're coming back to presentation of the day. 5, bringing your attention to this room. 4, feeling calm and relaxed. 3, start to wiggle your fingers and toes. 2, slowly start to move and stretch your muscles. And 1, you can open your eyes, feeling a little more rejuvenated. All right. Well, I can't see how anyone's reacting, but I'm wondering if anyone wanted to put a message in the chat, just how that felt for you in this busy August day to do a little bit of a music-assisted relaxation. And I'll put my guitar down for now. All right. So I wanted to give you a sense of what music therapy can look like. It can look a lot of different ways depending on the goal and the intervention. But today I want to walk you through a series of research studies that we've done over the years that demonstrate the role of sickle cell disease in things like pain management and the transition to adult care. Next slide, please. So I'm going to talk about the BEATS intervention that I did to address transition outcomes for pediatric patients moving to adult care. Talk about music therapy for acute pain, and then a survey that I did to prepare for the MSUIQOLS study that we did to address health-related quality of life among individuals with chronic pain, as well as some more recent real-world clinical practice data from music therapy and massage. Next slide, please. And so when I first started working at university hospitals around 2014, I was approached by the adult hematologist and the pediatric hematologist from the two programs. They were seeing how patients with sickle cell disease were very much engaged when they were working with me on the inpatient unit, and I was doing group drumming sessions, and they thought, well, music therapy is also a great conveyor of information. You can often remember, the lyrics to your favorite song. So could we use music therapy to address providing skills and providing education as, pediatric patients, age 14 and up are moving to adult care? And so we came up with this Beats program, and yes, this involves songs like the ones I'm about to demonstrate, but it also involved using practical props. So we'd have people imagine that their body is a city, and on that city you have streets, and on the streets there are red blood cells represented by these red city buses, and in the red blood cells you have hemoglobin riding the bus, and there's different types of hemoglobin that responds in different ways. And if the hemoglobin drops its oxygen, the blood cell can sickle. And then you have white blood cells and ambulances chasing down the viruses and bacteria represented by the Fast and the Furious cars, and all these different things. And it was a great way to sort of break down what are often sometimes more complicated laboratory values in this population. But to give you an example of a song, if you want to go to the next slide, this was a song we used to help patients understand these various laboratory values. So for example, a patient might create a rap like 8.6 is my baseline hemoglobin, the part of my red cells that does the O2 loading. If it's lower than this, I might need a transfusion, but call my doctor first so there's no confusion. 9.8 is my WBC, white blood cell count there to protect me from viruses, germs, and other invaders. When I have an infection, white cell count is greater. 0.777 is my usual reticulocyte count. That's my fresh mix of red blood cells coming fresh out of the bone. Retics become red cells when they're grown. 98% is my usual pulse ox. That's how much of the hemoglobin in my blood stocks. Oxygen, I breathe it into my lungs. It's carried through my body by hemoglobin, son, 'cause I can live well with my sickle cell. So we'd create that rap in real time as a group. Every patient would have their own, obviously for their own laboratory values. They'd have a card filled out by the hematologist, and this would help the patient remember these laboratory values so they could communicate them independently if they ever presented to a hospital. Another example of a songwriting approach we use in the next slide is blood transfusions. Blood transfusions can be complicated at UH. We do, 3 different types. And so I'll play you actually a recording of this rap meant to provide education on how the different blood transfusions work. So let me break it down so there's no confusion. For sickle cell, there's 3 main types of transfusion: simple, modified, partial, and full exchange. They do different things to help you maintain. When your red cells break open and your hemoglobin dwindles, sometimes we have to do a transfusion type simple to give you red blood cells that your body lost. We make sure we match the blood with the type and cross. To put the blood in, we hang it from an IV so it can go into your veins easily and help your red cells carry O2 with hemoglobin that's higher. But remember, this transfusion also gives you more iron.
It's the blood going through your veins when we transfuse. We can make a change to your red cells. Carrying hemoglobin is your life. We want it to keep on going. It's your life. And we want it to keep on going.
Now next, let's talk about the full blood exchange. So there's a little sample. That was a kind of a soulful rendition that we did. But similarly, in this exercise, we had red blood cells, and we had new red blood cells coming in. They had a bunch of magnets on them representing all the extra iron that comes in. So you had to take iron chelation with a mega magnet to pull it out. It was a good example of a collaboration between music and hematology education. Next slide, please. We did a brief, simple observational study of these interventions among 30 adolescents and young adults with sickle cell disease. And in that, we saw improved sickle cell knowledge on a test over the course of the study. We saw that music therapy was facilitating social support among these adolescents, young adults. They really enjoyed being able to share strategies with each other, pain management strategies, how to manage a pill box with each other. We also saw improved attendance to the adult sickle cell disease clinic over the course of that study, overwhelmingly positive feedback on evaluation. Patients really demonstrating a commitment to the intervention. They really wanted to come back and share different things that they were learning. Of course, in music therapy, it's not just the music we're providing, but it's the therapeutic relationship that we develop with these patients that's essential to the impact that we're having. And this was all feasible within a real world clinic setting. So I was embedded within Dr. Little's hematology clinic at Seidman Cancer Center. Next slide, please. And so I want to start pivot to the other dimension that is most frequently used with music therapy, which is addressing pain, sort of the hallmark of sickle cell disease. But even talking about that, I wanted to present this representation of pain. This was created by a patient who I worked with. She created this when she was working with the art therapist at Simon Cancer Center. And we asked her to draw what does a pain crisis feel like? Because often, you know, an integer on a 0 to 10 scale doesn't quite cut it. There's not a laboratory value that quite cuts it. But in this, it's, you know, razor blades in a punching bag in your abdomen. It's shattered glass in your chest, the feeling of acute SCD syndrome. It's electricity and pins and needles in your arms, that central sensitization, that chronic pain that can emerge. It can be fire in your legs. And all this can be present, and you're feeling it in your body, even if your face doesn't quite tell the story. And so this is the presentation of the individuals who I was working with. And it was quite daunting as a music therapist to try and figure out, in the midst of some of the most severe pain I think we could ever comprehend, how can a music intervention have an impact? Next slide, please. And so one of the first studies we did was we actually did a 3-arm randomized controlled trial comparing music therapy with a music therapist to listening to music on an iPod to no music among adult patients with sickle cell disease who are presenting to an infusion center with a pain crisis. Next slide, please. And so in this study, we recruited adult patients with sickle cell disease during their visits at the hematology clinic. And then the idea was, once they were recruited, we would wait to see when they might present to the acute care clinic, which was like our day infusion center, same-day treatment for pain. And at that visit, they would, again, then decide if they wanted to be in the study. So it was a big recruitment and then a large waiting game for these patients. But once they came and then agreed again to be part of the study, they were randomized to standard care plus either music therapy with a therapist or music listening, so listening to a Spotify playlist that they made when we recruited them, or a control with no intervention. This happened 1 hour after their first dose of pain medications, and we did a pre-test, intervention, post-test with visual analog scales for pain intensity, pain relief, mood, and pain intensity. And then we also interviewed them because this was a mixed method study. So we wanted to understand beyond, you know, numeric changes in symptoms, how did this impact individuals? Next slide, please. And so to demonstrate the intervention, what can be complicated in doing music therapy research is that you've got to take this very creative, individualized session where we're making music on the spot, and it's a very creative process, and you got to put it inside a research-sized box for a randomized control trial. And so to make this happen with this, we did this idea of a U-shaped music track. It's 20 minutes always. It followed a standardized template where the music gradually slows down from 70 beats per minute down to 55, kind of like that music we opened with, and then it comes back at the end. This is derived from some studies by Stéphane Guétin in France, where they use this kind of stuff in chronic pain research. And in the meantime, while I'm listening, the patient's listening via headphones, like you can see in the picture, we're also improvising together on a diatonic keyboard like this, where there are no wrong notes, right? So an example of the intervention, there were 5 different genres: R&B, gospel, hip hop, jazz, and soul. This is what the gospel intervention sounded like. So I could say something like, patient could talk back to me. I talk back. Maybe in the course of the intervention, we become a little bit more creative. And again, no wrong notes. But over the course of the intervention, people would become more involved, more engaged as the music gradually slows down. It was a good way to use all the different elements of music to facilitate relaxation and pain relief. And so if you go to the next slide, in this small study, it was a feasibility pilot, 20 people per group. We weren't powered for efficacy, but we did do a logistic regression analysis to see odds of greater than median improvement, a clinically significant change. And we saw that if you were in music therapy, you were 5 times more likely to have a reduction in pain intensity beyond 1.25 units. And you were 11.6 times more likely to have an improvement in mood as compared to control, which was a bigger effect than what we saw in music listening versus control, just listening to an iPod, where you were 5.7 times more likely. There weren't those positive associations with music listening as compared to control for reducing pain intensity or improving pain relief. And we saw no meaningful differences between the two music groups, no differences in terms of changing the numeric pain ratings, nurses' length of stay, or analgesic use. But beyond the quantitative data, if you go to the next slide, when we interviewed individuals, there were these two prominent themes. So in both music conditions, whether they were making music with a music therapist or just listening to music, there's this idea of, oh, the music took my mind off the pain. Like if music is here, pain is over there. We hear that a lot. Music kind of is like this drug effect that can have this immediate effect. There are a lot of things happening in the brain, a lot of neurotransmitter activity that can sort of supersede pain signals, lead to neurochemical changes, sort of that descending pain pathway, closing the gate control, whatever your theoretical orientation is. But music therapy does a little bit more than that. If you were in music listening, it was just kind of like, oh, it took my mind off the pain. But if you were in music therapy, they were talking about, oh, I enjoyed the intervention. It was more engaging. It was more relaxing. There was something additional that happens when you are doing more with the music than just listening to it through your ears. There's also something important about the music therapist. We're providing comfort beyond the music. We're creating a calming environment in an environment where patients often do not feel very safe coming to the hospitals day to day. We were able to provide a comfortable space we were described in positive terms. Patient like this one said, it helped me, it put me in a better mind state. Instead of thinking I'm in the hospital, I'm in the pain, I'm in agony, it was more soothing, like I was just at home relaxing. It soothed the pain a lot. I feel hopeful and optimistic. Had it not been for music therapy or the staff, I'd probably still be in the same mood that I was in. So lots of things that happen in response to music therapy beyond some sort of signal in the brain. We also got recommendations for making the interventions longer, allowing for changes in music preferences. Sometimes the music they chose when we recruited them was different than it was when they participated a year later. More music therapists and providing opportunities to address pain at home, which we do address in a later study. But so that's where we kind of started, right? What does 20 minutes of music therapy do when you're having acute pain? But we know many of these individuals, they have pain every single day. So I like this figure from Wally Smith and Shearer in 2010, where if you imagine age in years on the x-axis, going from 10 years old going up, and a pain scale 0 to 10 on the y-axis. This red line is sort of like acute pain crises that happen from when patients are very young, and pain goes up, and then they get treated, crisis resolved, pain goes down, and you have periods where you don't have any pain in between. But these crises continue to happen. But as you get older, 225 months, 240 months, 255 months, age 15, 16, 17, now that pain isn't going back down to 0. And now new types of pain are emerging. You might be developing avascular necrosis, that blue pain, that bone pain that is now coming up and it's just always there. Or you've had so many shocks to your nerves, to your nervous system, to the ways that pain signals transmit throughout your body, that now you have this chronic central sensitization or neuropathic pain. In addition to all that, some individuals, because they've been exposed to opioids over and over again, they might develop opioid-induced hyperalgesia, where actually the opioids are making the pain worse. And often opioids are not good at treating every type of pain. So patients might be in this very precarious situation in their early 20s or even younger, where they have multiple different types of pain, and the things that might have helped them before, like a brief dose of opioids when they're admitted to the hospital, are not helping with the pain that they're having every single day. And so if you go to the next slide, my thinking was, how do we go from this acute music therapy intervention that seems to be effective in small bits that I'm doing repetitively throughout the hospital when patients are admitted for pain crises? I want to get to the thing on the right, which is an intervention that patients can use every single day to manage their pain, like an exercise they can use. Before I did any of that, I really wanted to understand, how are patients just using music in general to manage pain? No one had ever asked that. There had been surveys of like biofeedback and prayer and massage and different integrative health and medicine modalities, but they never asked about music. And another problem was studies of music use for pain populations, they were done by mostly like older Caucasian folks, and they're listening to like orchestral music and slow piano music and, you know, very soft sorts of things. And I was like, that's not the kind of music these individuals listen to at all. We need to change what the literature says. And so in this study, we asked patients, you know, what music do you listen to when you have pain? And if you go to the next slide, we learned that it was 1/3 hip hop rap. You know, that 808, that beat, that repetitive nature, those hi-hats can be very soothing for our population. 30% R&B and soul, 13% Christian and gospel. It's not slow orchestral Mozart music. It's a different kind of vibe. 202 beats, 74 beats per minute, which is about the starting tempo of, on average, where we started the music intervention. At the time we did this, 2017, Drake, Kendrick Lamar, Kirk Franklin, Future, Mary J. Blige, 50% major, minor, patients around 22 years old when this is, when songs came out. And this might seem quite obvious for this population, but it's important to represent in the music therapy pain management literature, because if you're a music therapist working with this population, you better be very familiar with these genres to be able to use them in interventions with patients. And so get to the next slide. We asked some other questions as well, right? Which is, if you are listening to music to help with pain, what are you also doing at the same time? Lying down, I'm closing my eyes and taking my pain medications. I'm putting on a heating pad. I'm taking a warm or hot bath. You might recognize a lot of these as strategies patients use to manage pain at home. And we found that there was a correlation between two things. One was the number of strategies that you used. So you lie down, you close your eyes, take your pain medicines, put on a heating pad. Those are 4 strategies. And the outcome, which was on a 0 to 10 scale, how effective is music for addressing your pain? So there was this correlation between the more strategies you use, the more effective you found the music for addressing your pain. Next slide. And so, you know, that scale being 6.0 out of 10, patients also reported music distracting from the pain, so I don't think about it. It's kind of similar to what we saw in our first pain study. Helps with mood, helps me feel calm and relaxed. It lessens my stress, it helps me fall asleep, makes me feel encouraged. So again, we're seeing data where music is doing a lot of different things, and it really does matter what you're doing with the music, which is why we decided in our next study to do interventions where you are doing something with that music. You are breathing with that music. You're doing a progressive muscle relaxation with that music. And so if you go to the next slide, our recent publication, this MSUIQOLS study, looked to do just that. And so this is published in the Journal of Pain Research. Go to the next slide. In this study, we recruited 24 adults with sickle cell disease. Again, this was a small feasibility study, who had sickle cell disease and they had chronic pain, that AAPT criteria for chronic pain, where it's pain for, on most days, every month for at least 6 months, not explained by any other criteria. At baseline, we looked at self-efficacy, the PROMIS 29, which asks about things like depression, anxiety, pain interference, which is a very important outcome. The ASK-ME, which are sickle cell specific health-related quality of life measures. We also asked about their coping skills. They were then randomized to music therapy or a waitlist control. Before we did the intervention, they actually did 2 weeks of a daily pain diary, so we could get a sense of what pain was like at home. We collaborated with Dr. Krishnamurti and Ibakshi from Emory University, who had developed this before. Then if they're in music therapy, they got 6 sessions of music therapy or no intervention if waitlist. And then we did the outcome data in reverse. So 2 more weeks of pain diary afterwards, and then a post-test outcomes of self-efficacy, PROMIS 29, coping skills. And we also interviewed patients in the music therapy group to further explore accessibility, feasibility, and impact. Next slide, please. And so the intervention looked like this. I would meet with patients in a consult room just like this. I'd have a set of headphones, they'd have a set of headphones. We were hooked up into my mobile recording studio where all the music that we'd make together, we could hear in our headphones. It was pumped into my MacBook Pro. I could cut the track at the end of the session, give it to the patient, high quality audio experiences. The first session was all about education. What are your goals for therapy? I want to validate your pain experience. What does it sound like in your mind when you have pain? How can music address that pain? We actually had this model of the brain and the human body where there were these lights that traveled up to the brain and different locks that you had to turn that represented the different pain signals and the gate control theory of pain. So really establishing, you know, what is the function of music therapy for pain and what are your goals? For the next 4 sessions were all about teaching and exercise. So session 2 was very similar to what I did at the top of this presentation. We did a breathing exercise with music. For that, patients got to choose their beat on the iPad, personalize the music however they want. We cut that track in real time while we're doing the intervention in person. I give them that track and I say, I want you to do this once a day until we meet next time. Next session, progressive muscle relaxation, so tension and release throughout the body, again with their preferred music. Session 4, we made music to take them to a place where they felt most comfortable, whether that was the beach or the forest or their room or whatever it might be, and they would create the sounds of that place. What does it feel like? What does it smell like? What does it sound like? We would create that with music as like a music-assisted imagery exercise. Session 5 was active music making. So that same intervention we used in my acute study, we would make music together on an iPad, and then I'd show them how they could make music on their own at home using their own mobile device. And then in session 6, conclusion. So how are we going to plan to continue to use music exercises to cope with stressors as they emerge in the future? Next slide. And so the primary aim of the study was to look at feasibility. Can we do this thing? And the feasibility results were quite encouraging. We had an 89% consent rate, only one withdrawal. All of the pre and post-test measures, all of those different measures we asked were completed. All of the interviews were completed. We had high pain diary completion rates, about 70% at baseline, 66% at follow-up. All the people in the music therapy group attended all 6 sessions. They reported achieving their goals for therapy. All the interventions were accessible on their own devices. They didn't have to buy any new equipment to be part of this. The majority of participants reported using music interventions at least every other day, and the interviews revealed a high degree of usefulness and acceptability. Next slide. Even though this was a small feasibility study, we did run some comparisons to look at preliminary efficacy, and we saw meaningful and statistically detectable improvements in self-efficacy compared to control, as well as reductions in sleep disturbance, pain interference, and improvements in social functioning impact compared to control. The main outcome I'm most interested in is this pain interference. It's not your rating of intensity of pain right now. It's how much is pain interfering with your life? How's it interfering with your job? How is it interfering with your ability to play with your kids? The fact that we saw reductions that were statistically detectable compared to control at the same time that we did the study in Cleveland between September and December when the weather changes, like the worst time of year for having sickle cell disease, I think is rather encouraging for the study. And we're putting plans together to expand this study in the near future. Next slide, please. When we looked at interviews, again, this is very important. It gets deeper into how patients are experiencing these interventions. Again, we see this theme of it's taking me to a different place. It takes my mind off the pain, a new dimension. For those few minutes, I'm in a different world. But also patients are saying, I learned something new. I learned when I'm using these music therapy techniques, I can handle the pain a little better than usual. It had an impact on my ability to cope with the pain. Sometimes people don't know they have other options that can help them feel better other than taking pain medicine. So know that they have a way to feel better without those side effects, the drowsiness, the sluggishness that they get from pain medications is very encouraging. They say, okay, I can cope, which is what we were hoping to see with these interventions. Next slide. Patients also reported reduced need for pain medications. It gives things that they can do so they don't think about it. It's not there. I have other tricks to get rid of the pain other than taking pain medicine all the time, which is very important because you don't want to have a relationship with these pain medications where they're the only thing that you can use. You want them to work when you have that really severe acute pain, but you want to have other strategies so you can manage that pain and also do the things that you need to do day to day. And some patients even reported improved ability to manage daily tasks. Once you learn how you can manage things yourself, doing certain things become easier. I'd be able to do things like do more chores around the house faster because I'd be listening to this or breathing and my mind would somewhere else while I'm cleaning up. And I wouldn't really think about me and my bad knees popping while I'm trying to sweep. So again, music therapy becomes a strategy that they can use to be able to do things day to day. And so for this study, we found that music therapy was feasible for home use among adults with sickle cell and chronic pain. This may be useful for other chronic pain populations. Still, the music therapy research in chronic pain is very limited. It's still limited to pain intensity and not overall health-related quality of life. And this can be a framework for teaching strategies to people with chronic low back pain or fibromyalgia, and a framework for future music therapy research. We think music therapy can assist adults with sickle cell disease in reducing pain interference, improving sleep, improving social functioning, and then perceived ability to manage symptoms. You know, that self-efficacy improvement that we saw. But more research is needed to determine effectiveness in other settings, in other healthcare institutions, with other music therapists who are not myself. And so our future studies that we're planning right now also plan to use a more rigorous control condition, like a waitlist control or like a audiobooks or health education that are not simply a waitlist control. And so I want to conclude actually with what I've been doing more recently, which is these modalities in the real world as we're delivering them and documenting them in the electronic health record. What are we seeing throughout our health system when we're delivering these to hundreds and thousands of patients every single year? And so we have two studies. They're kind of sisters together. One was looking at adults who received music therapy, and one was looking at pediatric patients who received massage therapy. These were amongst individuals with hematologic or oncologic conditions. And so in each study, we looked at the effectiveness. So single session changes, what do you rate your pain at the beginning of the session? What do you rate your pain at the end of the session? And we compared people with sickle cell disease to people who did not have sickle cell disease, but had a cancer or other benign hematologic condition. And this is what we saw. So if you go to the next slide, and maybe click a couple times, you'll see some boxes sort of pop up on the screen. We found that in both groups, we saw clinically meaningful reductions in pain and anxiety, whether you had sickle cell disease or cancer, whatever it might be. When we compared the baseline scores, so when we first see you, how do you rate your pain? Pain was higher among adults with sickle cell disease. Anxiety was higher among adults with sickle cell disease as compared to people with other hematologic oncologic conditions. Also, people with sickle cell disease reported greater reductions, 2.89 versus 2.83, in their anxiety as a result of music therapy. There was also a higher rate of fatigue change greater than equal to 1 in the sickle cell disease group. So as I suspected, there's a different and higher symptom burden among adults with sickle cell disease as compared to individuals who do not have sickle cell disease. If you go to the next slide and we look at pediatrics in massage therapy, we see an even more drastic contrast. So if you click a couple times here, pain 7.20 in kids with sickle cell disease versus 4.26 in HEMOG. Stress 7.3 versus 4.1. Anxiety 7.18 versus 4.14. These kids have a much higher symptom burden. And one of the reasons I did this research was because I heard from other music therapists and massage therapists and other people providing integrative health and medicine modalities in children's hospitals where they said, oh, I'm funded to see the kids with cancer. Oh, I'm funded to see the kids who are on the bone marrow transplant unit. But the kids with sickle cell disease who are on the same unit, I'm not funded to see them. I don't see them. And I don't think that's right, because these patients have significant symptom burden and they can benefit from those modalities. So I hope if you're in the position to advocate for these services, you can use these research studies to demonstrate that these individuals do have a high symptom burden and they do benefit from these modalities. And as we're looking to the future, we're looking to multi-site research. Let's work together to look at the impact of these modalities to improve patient care. Let's take music therapy virtual. I think it worked decently well at the start of this presentation. Music can translate over an audio medium. Can that work to see patients who are scattered throughout a large state like California or Georgia? Can we intervene early? So don't wait to adulthood when chronic pain emerges, but let's detect chronic pain as it's emerging and start to deliver these interventions early. We actually have a qualitative quality improvement initiative that we're publishing right now that did just that thing in our pediatric clinic. Let's determine the efficacy of multiple integrative health and medicine modalities. These patients have lots of different types of pain: bone pain, nociceptive pain, neuropathic pain. It's probably the case that different modalities, whether they're yoga or acupuncture or massage therapy or music therapy, affect different pain dimensions differently. And I really want to understand, how do we optimize the combination of these modalities to best address the patient's needs and not be in a situation where we're just sort of doing a Cheesecake Factory type thing where you can choose from all these different modalities and sort of figure out, let's get better data to better coordinate these services. What are the effects on different dimensions of pain, the cognitive component, the neuropathic component, and then also getting down to, how is this happening? By what mechanism is this happening? What is happening in gene expression markers in the blood or under fMRI? Obviously, the music therapy is this neurochemical process. And we know from studies recently that neurochemical signaling around pain is different in people with sickle cell disease. So is the processing of music to address pain also different? Next slide, please. I do want to acknowledge I got into being a principal investigator on these studies when I was 24 years old with a bachelor's degree. No research happens without an incredible team, and I was very fortunate to connect with legendary sickle cell disease researchers like Coretta Jenneret, like Nadine Matthey, like Jane Little, like Dr. Krishnamurti, music therapists, statisticians who could do all these things that I did not know how to do. The research assistants, the Coolest Foundation, which is a foundation in Cleveland that has funded all of these music therapy research studies, the sickle cell disease teams that I've collaborated with, and the individuals at Emory University. And with that, if there are any questions, I would love to take them. Thank you for having me in California this afternoon.
Wonderful. Thank you so much, Sam. I know I found that incredibly insightful and interesting, and I just know that our audience has as well. We will begin taking questions at this time. As a reminder, the way that we take questions is through the chat box or the question function on the control panel feature of this webinar. And I will turn it over to Jackie to get us started if there's any questions.
Thanks, Niani, and thank you for that, Sam. Like just that initial intro exercise was really helped me refocus. Like I'm always trying to do a bunch of things at once, and that just took me to a very centered space. So I appreciate that. That's going to make this next part a lot easier because I was engaged. So I get it. So as we wait for any questions to come in, and please send them again through the chat box, I'm kind of curious if you can tell me a little bit more about, you mentioned home interventions and how people were able to use some of these stuff while they were not in the session with you. Did I hear that correctly? Can you tell me, like, how does that look like? What does that look like?
Well, it's kind of like a exercise training, right? You see a person, they would come see me, we would create this music exercise together, like this exercise in which they listen to music and do deep breathing, and they would go away with that audio recording of that intervention. And we would say, practice this at least once a day. So they become these skills, just like practicing yoga or doing a physical therapy exercise that you do every single day to, address those symptoms, address those stress, provide a way of coping, especially for a lot of our participants. They have a lot of stressors in their lives, whether it's little kids or dealing with a relationship that's a little bit toxic. That intervention became the way that they dealt with that to prevent that stress from elevating their pain. So it's trying to make music therapy a very practical type of thing. Let's create an exercise that we create together in the same space, but that you have that recording to listen to every day.
Got it. And I think it was in the next directions, you said something about potentially having some sort of app or something. Is that something you guys have thought about, or just future kind of directions?
I don't think so much about apps. I think about, like, obviously there's two perspectives on this, right? There are music therapy studies that involve a board certified music therapist like myself doing an assessment, coming up with an intervention. There's that relationship. And that's really important, especially with people who have really high needs. But there's other approaches that are, I call them music medicine, where here's this playlist to listen to. Here's the Spotify playlist. Here's the Spotify playlist that adapts to your personality. There's hundreds of studies like this in surgery where they're playing classical music or whatever, and it's been shown to reduce pain and reduce medications and things like that. So that's not the kind of research that I do, but that work is very valuable. And I kind of see them going hand in hand. Like if you have, you guys are, a lot of you are in the public health world. If you have a huge population of people, there are not enough music therapists to address the needs of all people with chronic pain. Some people could benefit just fine with an app that they can use, and that they have the self-efficacy and the self-management skills to do that. Other people need a lot more help to develop those resources. So music therapy does something that's a little bit more distinctive and intensive than just an app. And our early research showed that different things are happening from I listen to a Spotify playlist versus I engage actively in a music intervention.
Absolutely. And as we wait for questions to come in, I'm curious, like how often are there music therapists in like hospital settings? Is this a pretty common function of a hospital that they have a music therapist on staff, or is it pretty unique?
It's becoming much more common now. I think your top hospitals, your World News and Report hospitals do have at least one music therapist. They're much more common in pediatric academic medical centers, especially ones with large hematology oncology programs. So I know UCSF, the Benioff system has a great music therapy program that's worked with children with sickle cell disease, UCSD, UCLA. So that's not uncommon, but sometimes there might only be one or two. It's more rare in adult medical settings, but it is growing. Fortunate at University Hospitals, we have the largest adult medical music therapy program in the country. We have about 15 board certified music therapists on staff throughout our, I think 12 medical centers now. And especially as there's now this mandate from the Joint Commission and other accrediting agencies to provide evidence-based non-pharmacologic pain management, music therapy is one of those modalities. Mm-hmm. And some of the other research we've come out lately shows that, yeah, across 10,000 patients that we're seeing clinically meaningful reductions in pain intensity. And so we're using this research to also advocate for the growth of music therapy within the inpatient medical setting.
Thank you. So we have a couple questions. We have one from Taylor Marshall, who coordinates a monthly in-person sickle cell support group. Mm-hmm. Do you think music therapy is beneficial in a group setting?
Oh, absolutely. Yeah, it's definitely beneficial, but it's harder to coordinate. As this person probably understands, the hardest thing about groups is getting everybody in the same place at the same time. But I love doing groups. Like the Beats intervention was all groups, right? Everybody benefits from learning from each other. And if I could do this in groups as a research standpoint for pain management, I definitely would. It's just much harder to coordinate to get everybody in the same place and do the data. But you're absolutely right. It works very well in groups.
Would it function kind of similarly? It's just really getting people in the same spot, or would they be different types of exercises, do you think?
No, it'd be groups. A colleague, Yoka Bratt, she's a music therapist researcher at Drexel University, has done a couple studies looking at vocal music therapy in groups among urban African-American populations with chronic pain. And so there's group vocal exercises, there can be group music making, there can be sort of in this environment, sort of the group comes up with a setting of music together. We create music together, and then we experience a music-based breathing exercise together in that group. We've done a lot of different things like that, and it can absolutely work very well. And actually, probably there's quite a few studies now of these group music therapy interventions for chronic pain.
Great, that's good to hear. Another question is, what are the bottlenecks in having enough music therapists? Is it the workforce issue, or is it funding? I imagine maybe a little bit of both, but what's been your experience in that?
It's a supply and funding problem, absolutely. There's only so many music therapists. We're still in this situation where you have to be board certified, like I am, with a bachelor's degree to be a music therapist, but it's not a master's level entry program. And so sometimes that can be difficult to get accrediting or licensure. Like licensure for music therapy was just approved in Ohio. Music therapy in the vast majority of circumstances is not billable to insurance, especially in the adult medical environment. So a hospital is not going to be immediately financially incentivized to provide music therapy, but they become so. Things often get started because of a philanthropic grant or research grant. But then, like in our system, the hospital sees, oh, this is a tremendous benefit to patients, and it fulfills our obligation to provide non-pharmacologic pain management. So let's pay for it out of operational funds or as part of a bundled care model. So yeah, it's a care model thing where music therapy is not sort of a traditional billing service like your physical therapy or occupational therapy. And there's only so many music therapy programs and so many music therapists in the workforce currently.
And so do you have any tips for getting maybe a hospital clinic to really incorporate? Is it just showing them kind of some of these results that it is effective at managing pain, or is there another approach that you would suggest to start kind of introducing
I think it's different things at the same time, and I encourage people to reach out to me. And actually, my colleague Seneca Block is very, very good at this. He's the reason now where we've expanded to 12 medical centers. It is a combination of good therapy, good business, and good data, right? Right. Sometimes what makes the difference is an administrator seeing a music therapy session and realizing, oh, this is tremendously powerful, not only for the patients, but for the staff and the environment and staff stress reduction. Like we can do all those things. And then it's the data. So we've got my trials. I've got 4 studies releasing these Empire studies. If you look me up in PubMed that look at, we're having effects across thousands of hospital admissions, that could probably help. And then good business plans where you can see, for better or for worse, the cost of a music therapist in the hospital is not that much compared to a lot of the other things. So the cost benefit analysis, though we haven't done many formal analyses like that, there's quite a lot of benefit for the cost of employing a music therapist within a health system.
We have a question from another music therapist from a women's and children hospital and asking what was something that surprised you when you were looking at this data?
I think just to see the immediate benefit, I think things were moving in the right direction, certainly. But even in our clinical effectiveness research, to see that just the symptoms are just way higher consistently, and that we're seeing these differential effects, that's been surprising. I think, yeah, and I think it was also surprising to see just the total in our musical study. We got a lot of data points, right?
Mm-hmm.
Like it was way too many items, like 180 items at baseline and post intervention, plus the pain diary. But patients really wanted to demonstrate in the research, this is what I go through day to day, and that was kind of their motivation. And so they were motivated, even besides looking at the potential impact of music therapy, to say, I want you to know how much pain is really affecting my life day to day. The commitment to that, providing the data as it is, I think was surprising. I was tremendously grateful. And obviously none of this research would happen without the relationships that we developed with the patients at university hospitals.
Great. We have just a couple more questions. Next one is, what do we as SCD patients and affected family need to do to get the government to equitably fund this therapy for sickle cell disease? I'm not sure if you can answer that, but if you have any opinions on that.
Yeah, I think it's continuing to advocate and build those relationships. I think sometimes we are not even on people's radar. We get dismissed as just a fun thing in the hospital. Like a lot of people still think that we're like volunteers rolling up with a guitar and just like having a good time, and that's not what we do. You know, it always goes back to some people need to see it to understand the impact. Some people need to see the data, so I'm working on the data, and some people need to see the financial part. You know,
Right.
would you rather pay for just oxycodone prescriptions all the time? Would you rather do nothing and contribute to high healthcare utilization in this population if they don't have self-management skills? Or would you rather pay the relatively much lesser price of providing 6 to 8 sessions of music therapy, or it might be for some people massage therapy or acupuncture, and see dramatic reductions in healthcare utilization? Like even if you could reduce one emergency room visit, think of the cost of that visit. And so my job right now, as I see myself, is I'm trying to get the data and get it out so that great policy advocates, like I'm sure are on the call, can run with that data to their representatives to say, this is what's up. Just like I'm putting things out, and I've heard from music therapists around the country, we take your studies to our administrators and say, this is what's up. We should have music therapy for kids with sickle cell disease and not just the kids in the bone marrow transplant unit.
And the data are impressive. So I think it's important to keep getting it out there.
Yeah.
I have one more question, and I'm from another music therapist, which I'm going to potentially ask her to connect with you. She's curious about getting more information on the specific exercises that you guys did with the patients. So unless you want to elaborate on here, but otherwise I would.
You can feel free to reach out. I get this question a lot, and we've actually put together like we can provide details on how to do these interventions and some of the tracks through like a simple like licensing fee from university, or not even a fee, just a licensing agreement from university hospitals. We can provide you some things. All this stuff is made in GarageBand. Like I'm not using like super fancy expensive software or anything like that, but I'm happy to do that. And in the near future, we're going to be expanding some of this research, and I'm actually going to be in the position of not being the music therapist, but the person training the other music therapists to do this stuff. So very soon I'll be in a position where I'll actually have some detailed manuals that I can provide and things like that. I'd be happy to show those things if you want to reach out.
Great, and that was actually going to be my question, is plans to kind of expand this beyond you, because I know you can't be
so stay
everywhere.
tuned. I can't say anything right now, but stay tuned. There's going to be things happening that are going to expand this research that I'm very excited about. yeah, we're just going to keep going, basically. And as my role as this integrative health research and data specialist, I am about not just music therapy, but let's bring everybody in. You know, let's build comprehensive programs that have all the modalities there to best meet patients' needs. Let's bring in acupuncture. Let's bring in music therapy. Let's bring in massage therapy. Let's detect things early. So you'll see that emerging from the research that we're generating from university hospitals. And some new trials that should be coming online. So, yeah.
Wonderful. Well, thank you for that presentation. And if there are any further questions, people can email us and we'll be happy to pass those on. And Niani, I'll pass it back to you.
Sure. Yeah, thank you so much. That was a wonderful presentation with some really great, strong data. So I can't wait to see what the future holds and to be following your work. And I will definitely connect those who are asking questions to you via email. I also wanted to share with folks the ways to get connected with our program, the work that we do, to get plugged into the webinars, newsletters. All of that is on the screen for you, which is at trackingcalifornia.org or casicklecell.org. And we're also pretty active on our Facebook and sometimes Twitter. And at this time, this concludes the time that we have allotted for this session. I just want to say a special thank you to our speaker, Sam, as well as our internal SCDC team. Upon ending this webinar, there is a brief 3-question survey that can provide feedback for this webinar. You can ask additional questions as well as suggest future speakers. So please take a moment to fill that out. We greatly appreciate it. I want to thank everyone that's participated and joining us today. We appreciate you being here, and we will talk to you next quarter. Thanks, everybody.